Hello, the topic for discussion today will be infections and tumors of larynx. As we all know, larynx is also called as voice box because it is the important organ which is responsible for phonation, for speech, for producing various sounds, etc. Now, when we're talking about, before going into the various infections and tumors of larynx, to briefly explain you about it, normally larynx is located in the anterior neck region. Normally it is located in the bifurcation region where your pharynx is being separating or bifurcating into esophagus and trachea. It is located at that junction of the of this part, and this normally connects pharynx to trachea. Larynx is an important function other than phonation, where it will protects the lower airway from any ingestion or any inspiration of any noxious or foreign bodies. Okay, but how does it do it? It will do it by if there is any mechanical obstruction or mechanical abrupt mechanical stimuli is present, it protects by abruptly stopping or preventing respiration. So thus inspiration will not happen, leading to prevention of that inspiration of any foreign material. Now this larynx, grossly it is actually made up of 3 paired cartilages and 3 unpaired cartilages. The unpaired cartilages are the larger ones, and these 3 unpaired cartilages will include our cricoid cartilage, thyroid cartilage, and the epiglottis. And the 3 paired smaller cartilages includes the cuneiform one, the corniculate, and the arytenoids. Arytenoids are the one which are actually responsible. I mean, they are with the vocal cords. They are responsible for phonation, whereas the cuneiform, it is actually in the club shape. Okay, that's the reason it has the name cuneiform. And corniculate, it is in a horn shaped one. That's the reason it got the name as corniculate. And this actually we have hyoid bone also, not intricate part of the larynx, but it will help in attachment of the muscular attachments. Hyoid bone is responsible for the muscular attachments to this larynx. And epiglottis is actually a spoon shaped one, where it will made up of elastic cartilage, and it has this protective action, preventing the ingestion of any foreign particles entering into the trachea. So that is briefly about the actual structure of the gross anatomy of larynx. Now coming to the infections, various infections that are causing and which are encountered with the larynx. We have the most important one is laryngitis. Laryngitis, as the name itself indicates, it is inflammation of larynx. It can be either acute or chronic, and based upon the etiology, it is again of various steps. We have TB, tubercular laryngitis, tuberculous laryngitis because of the tuberculous organism, and we have mycotic laryngitis, nothing but it is caused because of any deep fungal infections involving larynx, thus leading to inflammation of it. And we have other kinds of laryngitis based upon the bacterial ingestion or the viral ingestion, etc., the infections from bacteria or virus. Normally, this laryngitis can be grossly divided into acute and chronic laryngitis. As the name itself indicates, acute, where the symptoms that are being associated with laryngitis are shown very spontaneously or very immediately. Whereas the chronic laryngitis is a condition where we see the symptoms of larynx usually present for greater than 3-week period of time. If it is remitting, will immediately after giving medication and all responding well within less period of time, that is within 1 or 2 weeks. Usually laryngitis is self-limiting. If if it is of the period of 1 to 2 weeks of period, then it is called as acute laryngitis. But if the symptoms persist for greater than 3-week period of time, then it is called as chronic laryngitis. And the onset of laryngitis is usually very abrupt. The etiology for this laryngitis, or the risk factors for laryngitis, could be any vocal abuse, most commonly seen in teachers, in singers, the trumpet players, in the glass blowers, etc., where the vocal especially the vocal cord users, where there is abuse of vocal cord for a longer period of time, the chronic abuse of vocal cords. And also any toxic agents, these toxic agents could be the atmospheric pollutants could be there, or any noxious stimulus or gases, noxious gases, etc., could be toxic agents. And viral and bacterial infections affecting the larynx, and also GERD, that is gastroesophageal reflex disease, can also lead to laryngitis because of the esophageal reflex causing that acidic nature of that, leading to inflammation of the larynx, thus can lead to laryngitis. Normally, how this laryngitis appear, the pathophysiology is, normally the larynx will, which has been affected by laryngitis, will be usually congested and will be edematous, mucosa will be present, which will further have, the next step will have fibrinous exudate, and then there could be cartilaginous involvement also in the later stages of this laryngitis. Okay, and this is a picture which is actually showing us a normal larynx. Then we have vocal cords there. If you see the inflamed larynx there, we could see that congestion and edema, and also the space, the vocal cords are being collapsed. They are like, they came nearer in the next picture, that is in the case of laryngitis. And sometimes what happens in laryngitis, the perichondrium of the laryngeal cartilages could be involved, which could lead to perichondritis. Okay, when the perichondrium is involved, it can lead to perichondritis again. And other etiological factors which we can talk about is smoking, any psychological stress, also physical stress, where vocal cord abuse is been more encountered. In those cases, we can see this laryngitis. Then coming to clinical features, the most common clinical feature is acute or sore throat, severe sore throat. Patient will have, because of sore throat, they'll have dysphagia, there is difficulty in swallowing. There will be odynophagia. Odynophagia is nothing but painful swallowing. When they swallow, patient feels that pain. There's tender larynx will be present. Sometimes lymphadenopathy can be present. Will be change in the voice because the vocal cords are also been disturbed there. There could be change in the voice. Dyspnea. If there is an edema, as we have seen the pathophysiology, there could be edema of the larynx. When there is edema of the larynx, what happens? The tracheal space is being compressed, okay, or it is narrowed down, leading to dyspnea. There will be difficulty in breathing. There will be stridor, and also, as we said, there will be tender larynx. Sometimes patients will also have otolgia in some cases. Okay, then coming to other laryngeal infections, we have other laryngeal infections like acute epiglottitis. We have laryngotracheal bronchitis. As the name itself indicates, it involves a larger area of the larynx, also called as croup. And we have diphtheria as other laryngeal infections. Now coming to this acute epiglottitis, as the name itself tells you, it is nothing but inflammation of glottis, epiglottis, right? And acute epiglottitis is a very potentially fatal condition. Usually it is an acute medical emergency, most commonly seen in younger age group children. Pediatric emergency it is usually caused by Haemophilus influenza type B. Okay, acute epiglottitis is caused by Haemophilus influenza type B. Okay, and this epiglottitis may actually involve the supraglottic compartment. When it is involving the supraglottic compartment, what happens is there can be obstruction, there can be breathing difficulty. Okay, this patients will exhibit with sore throat dysphagia. The sore throat is so acute that it just snaps out within few hours of time. And patient will have dysphagia, there will be inspiratory stridor can be present, and within 2 hours the child can collapse. Okay, in this acute epiglottitis, as I already told you, there will be breathing difficulty, right? There will be dyspnea. So what happens is the child, when actually laid flat, cannot take the breath inside. So what they does is they try to sit up with hands backward like this, and they try to sit erect to take the breathing. So this particular sign of sitting erect and supporting themselves with hands placed at the back side, it actually forms a shape of tripod. This is the region in acute epiglottitis. A clinical sign of tripod sign is also seen. Now in X-ray, when we actually, apart from the clinical features, when we actually go for your X-radiograph usually gives us a plain neck radiograph, will give a sign of thumb. Okay, that is sign of thumb is because there will be edema of this epiglottis leading to a thumb sign, which is frequently seen on a plain neck radiograph. Okay, and then the treatment for epiglottitis, usually cephalosporins are the drug of choice, and we have certain complications of this epiglottitis, and those complications can include epiglottic abscess, we can have pulmonary edema, and also there can be thrombosis of internal jugular vein. So this is about epiglottitis. And the next laryngeal infection is laryngotracheal bronchitis, also called as croup. This laryngotracheal bronchitis, as the name itself involves, it includes a larger area, that is larynx, some part of trachea and bronchi is involved, and usually this involves a subglottic, that is below the glottic phase, subglottic, and this croup is usually seen in young children and young adults. It is again an acute illness. The most clinical or characteristic feature of this laryngotracheal bronchitis is hoarseness of voice. Patient will present with a peculiar cough, that is barking type of cough. When they cough, patient usually have that barking type of sound called as barking cough, and obviously there will be respiratory distress in these cases of laryngotracheal bronchitis. It is usually caused by a viral infection. Most commonly paramyxovirus is the most causative organism. We have para-influenza virus 1 and 2. We have cytomegalovirus, especially in the adults we see this HSV, herpes simplex virus, cytomegalovirus, and also influenza virus. Normally, in case of this laryngotracheal bronchitis, we see something called as subglottic edema. Okay, this subglottic edema is responsible for the respiratory distress that is caused in this laryngotracheal bronchitis. So when we are going, apart from the clinical symptoms, when we actually go for investigation, a plain chest x-ray, a plain neck x-ray will actually give us a characteristic sign called as steeple sign. Steeple is nothing but, on the top of the churches we have the steeple, right? So this will give a characteristic steeple sign, which is because of narrowing of subglottic area. Because of narrowing of the subglottic area, we have a characteristic steeple sign. I'm repeating, characteristic steeple sign, which is seen in case of this laryngotracheal bronchitis. We can see that in the X-ray which has been here. Okay. And this is also, we can also see ballooning of hypopharynx in this laryngotracheal bronchitis. And next one is diphtheria. Before going to diphtheria, another laryngeal infection we have is whooping cough or pertussis. This whooping cough or pertussis is caused by Bordetella pertussis, normally seen in young children who are not been immunized, and also in some of the adult patients who are immune compromised, who are very susceptible for this Bordetella pertussis. Normally, patients usually complain of running nose, they have dry cough, they have pyrexia and common cold. Okay, this is again one of the not so commonly encountered one is whooping cough. Because of the good immunization that we are having nowadays, we're not frequently encountering this whooping cough. And then the other laryngeal infection, as we have will be discussing, is diphtheria. As we all know, diphtheria is caused by Corynebacterium diphtherium. It is again caused because of droplet infection. The source is because of droplet contamination, because when patient coughs or anything. And also patients will have this running nose, right? And even diphtheria is caused seen in cases of children who are not immunized. Okay, non-immunized children, and in particular adults who are susceptible for this, again, Corynebacterium. The most common areas that have been involved in diphtheria, we have tonsils, we have the facial pillars, nasal cavity, and finally the larynx, which has been involved. The characteristic feature of diphtheria is we have a gray membrane which is present within the in the oropharynx region. We have a gray membrane, which is a characteristic feature of diphtheria, which we can actually see that in the picture. Okay, gray membrane is seen in the oropharynx region, especially at the tonsillar and the facial pillar region in the picture. And patient will have sore throat, they will have malaise, pyrexia, dysphagia as other common clinical symptoms. So apart from this, we have something called as Rinke's edema. Rinke's edema, also called as polypoid chorditis. In this, what happens? We have edema of the vocal cords. Because of this edema of this vocal cords, what happens is there will be change in the voice. Okay, then patient will have voice change, hoarseness of voice will be present, and there can be respiratory stridor also in these cases of a Rinke's edema. So now coming to the investigations, what investigations we do before going into the diagnosis of these laryngeal infections. The most common one is, first, a complete blood picture has to be taken. If there is any infection, as we know, the leukocytic count will be elevated in these cases, and in cases of this, when we have a doubt about the, for example, diphtheria or any bacterial infections, then we go ahead with culture, whereby the throat swab will be taken and it will be done, we'll actually go for a culture of this. And X-ray is again a good sign which will help us in identifying the type of disease it is. For the croup or tracheobronchitis, laryngobronchitis, we have this steeple sign, and thumb sign will be seen in case of swollen epiglottis. Like this, we can actually see, by having a lateral X-ray radiograph of the neck or direct X-ray, plain neck view, we can actually identify some kind of radiographic features. Then computed tomography, that is the CT, is again a best diagnostic aid, radiographic diagnostic aid in case of this. If we suspect any case of malignancies, any case of tumor or any bony changes, in those cases we can go ahead with this computed tomography. Now coming to the management, the first line of therapy for infections is IV antibiotics. We have to go for IV antibiotics in some cases, and otherwise we can normally we can take oral antibiotics. Oxygen, oxygen has to be given to these patients, especially when we see respiratory stridor. In those cases we actually have to give oxygen to the patient. And then anesthesia has to be given in upright position. This is because when patient is actually sleeping, there will be more amount of dyspnea, there will be more amount of obstruction for airway. And laryngoscope, in case when we actually think we have any laryngeal infections are present, then we if you are not completely convinced with the diagnosis of radiograph, then we will go ahead with laryngoscope. And tracheostomy and nasogastric tube for feeding has to be done in very severe cases. Now coming to the benign tumors of larynx, normally when we talk about the tumors of larynx, they could be broadly classified as non-neoplastic and neoplastic. And in non-neoplastic tumors, we have various conditions. Non-neoplastic itself means that they're not true neoplasms, and we have various conditions like ocal polyps and nodules. We have contact ulcers, intubation granulomas, amyloidosis, leukoplakia, cyst, and laryngoceles. Now coming to this ocal polyps, this is again due to ocal abuse, okay, our misuse of the ocal cords, especially seen in singers, in teachers who shout or who scream loudly. And these ocal polyps are also seen in cases of patients who have allergy and who are chronic smokers. Okay, even in chronic smokers also we see this case of ocal polyps. They are usually unilateral, they are soft, they have a smooth surface, usually pedunculated, and these usually caused because of when patient suddenly shouts, there could be a hemorrhage within the vocal cord leading to submucosal edema, and this submucosal edema will actually be seen as this ocal polyps. And the clinical features include hoarseness of voice. Again, patient will have dysphagia. If the polyp is so big, then patient will have difficulty in breathing because of the obstruction of the airway. Next, we have something called as ocal nodules. Ocal nodules are also called as screamers nodules or singers nodules. Why screamers nodules? It is because some patients have this habit of screaming loudly, or the vendors who actually sell things on the streets, okay, they actually scream, they shout loudly. Because of that, what happens is we actually see this ocal nodules, and this is also because of misuse of the ocal cords, and they are actually symmetrical in nature. They have a free edge, they're symmetrically present at the free edge of the ocal cord, okay, and this could be because of the ocal cord trauma. Next, we have something called as contact ulcer. Contact ulcer is again also because of the voice misuse. In this, what happens is actually there will be faulty voice production. In some patients who actually do some mimicry kind of thing or faulty voice, they scream loudly, etc. In those cases, we see this where they'll actually cause a friction between the the vocal processes. There'll be we have the vocal processes, right? Actually, they're like this. When we are shouting, they actually move like this, right? When we are actually causing some sound which is not, we are doing a faulty voice production. In those cases, what happens is these ocal cords, this ocal process of the arytenoids will have the friction between them. They actually contact and they cause friction between them, or because of any laryngopharyngeal reflex, they will cause a friction, thus causing contact ulcer, and this also can lead to voice change or hoarseness of the voice. Then intubation granuloma, one of the most commonly encountered one, especially in GA patients. Okay, what happens is injection, there will be infection of the vocal process of arytenoids because of this intubation. Okay, when we actually do the intubation, rough intubation especially, it can cause, there can be an infection, or there can be any rupture, there can be mucosal ulceration, which further leads to granuloma. Again, hoarseness and dyspnea are common clinical features, especially in this case of intubation granuloma. Next condition is amyloidosis. As we all know, amyloidosis is nothing but the deposition of the amyloid material within the larynx, and because of this, what happens, it will be edematous in nature. It has a smooth surface, soft smooth swelling is usually encountered in case of this amyloidosis, and on usually in such cases of amyloidosis, what happens? It could be a generalized condition also. There could be some amyloid deposition in other body parts also. Next is leukoplakia. Leukoplakia is nothing but keratosis of the larynx. Okay, because of this keratosis, what happens? You can actually see that localized white hyperkeratosis area on the larynx, and especially when you actually see with the laryngoscope. And this leukoplakia of larynx has an important thing that it has it is actually a potentially malignant one. The leukoplakia is actually a potentially malignant one, where it has propensity for converting into cancer, or it has a high malignancy transformation rate. Next, we have something called as cyst and laryngocele. Cysts are one of the common conditions that we encountered in case of this larynx, and laryngocele is also a fluid filled, especially an air filled balloon or air filled bubble that is actually seen in case of your larynx. That is our non-neoplastic lesions of the larynx. Now next, we have various neoplastic lesions. This can be either benign or malignant, and the benign lesions, to name them, we have hemangioma, rhabdomyoma, fibroma, lipoma, chondroma. We have various glandular tumors and granular cell tumors, and finally the carcinoma of larynx, which is again a malignant one. Hemangioma, as we all know, it is nothing but a benign tumor of blood vessels, which will have endothelial proliferation there. In case of hemangiomas, what happens is patient will actually have a benign swelling there. It will be like light purplish blue in color. And rhabdomyoma is again, we have a skeletal muscle tumor there, and it is again a benign condition. Fibroma, it is a benign fibrous growth, and lipoma is benign adipose tissue growth or proliferation, and chondroma is again a benign tumor of the cartilage. And we have various glandular tumors, a minor glands which are present within the larynx, and mucus secreting glands, etc. In those we can see these glandular tumors. Granular cell tumors are also seen, especially in case of any granulomatous conditions which are affecting your larynx. And the final malignancy one is again a squamous papillomas. Squamous papilloma is again a benign tumor, which we have papillomatous warte cauliflower like growths will be seen on the surface of the larynx. This is nothing but squamous papillomas. In the neoplastic, malignant neoplastic, the most common that we encounter is a carcinoma of larynx. This carcinoma of larynx is usually seen most commonly in case of men. In age group of between 40 to 70 years of age group, carcinoma of larynx is usually encountered. This carcinoma of larynx could be of varied etiology. Okay, this etiology is multifactorial. It could be because of habits, especially if the patient is a chronic smoker, or if the patient has the habit of the alcohol, where it actually acts as a synergistic effect. The alcohol and the smoking habit will actually act as a synergistic effect, which can have a propensity to turn into carcinoma of larynx. Any neck irradiation, if patient has underwent any neck irradiation, for example for thyroid carcinoma, etc., in those cases what happens, it can also further lead to, as a secondary, it can lead to carcinoma of larynx. And then we have genetics as one of the one of the common cause for it, and occupational hazard also. Occupational hazard, especially in case of glass blowers and patients who are working in the glass industry, right? In those cases, we can actually see this carcinoma of larynx. And also in case of this inhalation, patients, if they're inhaling any asbestos companies, etc., in those conditions also we can see this carcinoma of larynx. Now this carcinoma of larynx, based upon its position it is involving, it is again classified into subglottic, glottic and supraglottic. Subglottic, as the name itself indicates, it is present below the glottis. Okay, the most common location is below the glottis. However, it is very rare. Subglottic CA of larynx is rare. It is actually has a circumferential spread. It will has that patients will have stridor, hoarseness of voice. Usually this carcinoma of larynx is again a slow killer unless it is growing bigger in size and causing the difficulty in respiration or compression of other adjacent structures like your internal jugular vein and also the recurrent laryngeal nerve. Unless it is causing that compression, usually it goes unnoticed and it comes in a very advanced, patients usually come in a very advanced stages. And glottic carcinoma, usually it affects the middle 1/3 middle third of it, especially in the free edge or upper surface, and supraglottic, it is usually greater, most commonly seen in case of epiglottis in the vocal cord region and arytenoid folds. This is based upon the location, it is divided into these types. And then the most common clinical features, odynophagia, patient will have painful swallowing, pain while swallowing. There will be a large neck mass can be seen in these cases. Hoarseness of voice when the arytenoids, especially most commonly encountered in case of supraglottic location of the carcinoma of larynx. Referred pain to ear can be seen because of the compression of the recurrent laryngeal nerve. And then we have respiratory obstruction can be seen, and also patient will have unexplained weight loss, unexplained loss of appetite can be seen in these cases. And coming to diagnosis, the history plays very important role. Patient's habit history, any radiation history, the clinical, the features that patient usually gives, the clinical symptoms the patient usually gives, also will actually lead us into a proper diagnosis. The lesions are usually exophytic or they can be ulcerative in nature, and normally sometimes what happens is the vocal cord mobility is usually fixed or decreased. We can see the neck node enlargement. These neck nodes which are enlarged can be again stony hard in nature, painless. There can be have the nice spherical shape instead of the ovoid shape. All this neck node enlargement symptoms can also be, signs can also be evaluated. And then we have extra laryngeal spread in some cases. Now the soft tissue lateral view of neck will help us in identifying any lump or mass, and then laryngograms with contrast will help us for better diagnosis, and direct or microlaryngoscopy can also be done. Now coming to the management, we can actually go for radiotherapy or surgery depending upon the size of the lesion. If the lesion is very large and where surgical excision cannot be done completely, so in those cases we go ahead with radiotherapy first, hence the lesion will be shrunken, okay? Then we can actually do surgery so that the surgical defect would not be very large. And also in cases where surgery is inaccessible, or when this lesion is actually present near to the blood vessels or nerves, in those cases also we can go with radiotherapy as a treatment of choice. And when it coming to surgery, we actually can go with a conservative approach or total laryngectomy. This total laryngectomy is actually advisable to prevent the recurrences. However, we should also check for other complications post the total laryngectomy. And then sometimes we can actually go ahead with this combined radiotherapy and surgery. So this is about the larynx, and we have dealt about various infections which are associated with larynx, and also the various tumors that have been associated with larynx. Thank you.